Today we're going to talk about hypercoagulable states, and I'm going to try to do a quick review of everything and really talk and focus on the secondary hypercoagulable states, which means that it's not genetically inherited, it's acquired through something that's happened in your life. Now, all of this talk about hypercoagulation makes me think about that one song well, I swear it's about clotting. It says, "I want to take clots with somebody." I wanna take shots with somebody. Shot. Yeah, that's the song. So this table comes from Robbins and Cotran, Pathologic Basis of Disease, and so it's broken down. You can see that we have the primary, which are genetic, and you have common, rare, and very rare. Then you have secondary, and they're not broken down by their frequency. They're broken down by their risk for thrombosis, so high risk and low risk. This is in the study guide, so you can free to download it and memorize it if you want. But just to orient you to where we're at, we're talking about thrombosis. We're talking about Virchow's Triad, which is the three major groups that give you thrombosis. You'll remember endothelial damage, stasis of blood flow, and hypercoagulable state. Each one of these really could be broken down into whether or not they're genetic or acquired. However, in most books and practice and everything, the only thing that's really broken down like that is the hypercoagulable state. But because of the nature of this, and because of the nature of looking at genetic versus acquired, there are some things where we're going to look at that are really endothelial damage, but in Robbins it gets classified as a hypercoagulable state. For example, homocysteine, increased levels of homocysteine due to things like folate and B12 deficiency. So homocysteine due to B12 or folate deficiencies. So low levels of these probably cause endothelial damage leading to the hypercoagulable state, and there's a few other theories on what's causing coagulation in increased levels of homocysteine. So my point is, even though these are the three large groups, there is a little bit of overlap, and so we'll take a look a little bit at each of these, especially looking at acquired versus genetic. And just take another step back really quick. We are looking at thrombosis. This is in the category of hemostasis, pathologies associated with hemostasis. And to the two broad categories you have are bleeding diatheses and thrombosis. Now, there is some overlap in these two groups as well, because in thrombosis, you have coagulation when it shouldn't be. And there are a lot of situations where you have coagulation that ultimately leads to a bleeding diatheses. A few examples of this would be TTP and HUS. Both of these cause microangiopathic hemolytic anemia. And what happens is they will form, in the microvasculature, they'll form little clots. And when the blood cells go across there, they'll shear. And this usually happens with DIC as well. But the thing with DIC is you're looking at the different, typically with different causes. So you could classify TTP and HUS sort of as sometimes they will present as a DIC. But the thing I want to point out is that in these diseases or in these pathologies, you are really, the primary problem is a thrombolytic or a thrombosis problem, a problem with coagulating when you shouldn't be, and that ultimately consumes platelets, it consumes clotting factors, and allows bleeding to happen in other areas. So the bleeding in these cases is secondary. Now, since we're talking about Virchow's Triad, let's take a few seconds to understand these first two, and then we'll move on and really get to the focus of this presentation. So with endothelial damage, you'll recall that we have our blood vessel, and the blood vessel is lined with endothelial cells, and those endothelial cells actually prevent clotting. They do a lot of things to prevent clotting. The first is they produce PGI2 and nitric oxide. So they have production of things, and they protect. So they protect by blocking the subendothelial collagen. So you'll imagine this red being subendothelial collagen, and whenever that is free and there's nothing blocking it, you'll have the binding of von Willebrand factor, and von Willebrand factor initiates the primary hemostasis. It initiates the platelet plug. Now what I want to point out really quick is that we have von Willebrand factor being produced by the endothelial cells that are produced in the Weibel-Palade bodies, and two things will happen to them. They will be secreted out into the plasma, so first is they are secreted, and the second thing is they can also be laid down directly onto the subendothelial matrix. So they can be put down onto that collagen, and the endothelial cell will still sit right on top of it. And so what happens is when that endothelial cell dies, it doesn't need more von Willebrand factor to come in and sit on that collagen. It already has some there. But that extra von Willebrand factor will go there anyways and increase the speed and the amount of the platelet plug. So you've already got some here. And so by virtue of the endothelial cell sitting on top of that, it protects it from the new von Willebrand factor from binding, and it also protects the platelets. They can't see the subendothelial bound von Willebrand factor. So there's two things: it's stopping the platelet from coming in and finding this, and it's also stopping this from coming in and increasing this. So that's what I mean when I say that it protects. Now the next thing is it produces PGI2 and NO. So what is PGI2? So I'm secreting PGI2, prostaglandin I2, also known as prostacyclin, and then that PGI2 will find my platelet. Now if we zoom in on this platelet to see what we have going on inside of it, you'll see that the platelet has a lot of ADP. And you'll notice the ADP, it's made out of that nucleotide. It's the nucleoside adenosine, and so you have adenosine adenine diphosphate. And what PGI2 does, so I've got PGI2, is it will come in here and it will increase the amount of cyclic AMP, cyclic adenosine monophosphate. So if it's increasing cyclic AMP, it can only do that one of two ways. It can increase the de novo synthesis of adenosine, or it can borrow some of this other stuff. So you got ADP and ATP, and AMP, so you can borrow some of these other A's to create your cyclic AMP. So you're going to reduce ADP levels within the platelet. PGI2 does one other thing. So you have the enzyme cyclooxygenase. I'll just draw it as a little box here. And cyclooxygenase likes to take this phospholipase A2, so phospholipase A2, and it likes to turn it in, for the cyclooxygenase inside of the platelet likes to turn it into thromboxane A2. But PGI2 will actually come down here and inhibit cyclooxygenase. So the net result of all of this is I get decreased levels of ADP, and I get decreased levels of thromboxane A2. And you'll remember from review that these are both things that increase the expression of glycoprotein 2B3A. So glycoprotein 2B3A. And that glycoprotein 2B3A is what allows platelet aggregation. So let's zoom back out here and take a look really quick. When we talk about the protective role of endothelial cells, we're talking about platelet adhesion, and when we talk about the PGI2 and NO, we're talking about platelet aggregation. Now there's a third thing with PGI2 that you should also be aware of. PGI2 and NO both cause vasodilation. So vasodilation, and you'll remember that the very first step of hemostasis is vasoconstriction. So vasoconstriction is the very first step. Vasoconstriction is the very first step in hemostasis. And if I don't have anything to fight that vasoconstriction, if I don't have NO or PGI2, if I have reduced levels of those, I don't have anything to fight that very first step of hemostasis, I'm going to get increased risk of clotting. Now the next thing I have listed here are heparin-like molecules. So for this, we'll zoom into the endothelial cell surface. The endothelial cell surface has a bunch of heparin-like molecules on the surface. And what these will do is they'll take antithrombin 3, inactive, and convert it into antithrombin 3 active. So this is active antithrombin 3. And you remember that antithrombin 3 will inhibit thrombin mostly. Primary effect is on thrombin, but it will also inhibit factor 9, factor 10, and when I say all these factors, I'm talking about activated factors. Active factor 9, active factor 10, active factor 11, factor 7. It also inhibits C1 from the complement. It inhibits the C1 subunits because it's a serine protease. You remember that the C1 used serine for catalytic activity. And last, it will also inhibit kallikrein and then, to a lesser extent, plasmin. So going back to our coagulation pathway, we've got the intrinsic and the extrinsic. And then, of course, down here is the common pathway. And so what are we inhibiting? We're inhibiting factors 10, factors 9, factors 11, and then, of course, factor 2. Factor 2 being prothrombin, or whenever it's activated, it's thrombin. Prothrombin. And then also factor 7. And just as a reminder, factor 3 is also known as tissue factor. It's also known as tissue thromboplastin. Factor 1 is also known as fibrinogen. And the whole goal of this whole thing is to turn fibrinogen into fibrin. And so these heparin-like molecules that we started off with, these are the heparin-like molecules that we're starting with. These will activate antithrombin 3, and antithrombin 3 will inhibit these factors. And by inhibiting these factors, we will get an inhibition of conversion of fibrinogen into fibrin. In other words, you won't have secondary hemostasis. The next two things, Tpa and thrombomodulin, we'll look at the same time because both of them require thrombin. So let's suppose I have this nasty little clot over here, and it's got a whole bunch of fibrin cross-linking because of the thrombin activity. So I'm going to put a little T here for thrombin. Thrombin has been here. There's been a lot of it. But assume that my blood is flowing this direction, and so some of this thrombin is being carried downstream. And I say it's getting carried downstream. First of all, when it gets carried down through the blood vessel, it actually dilutes it enough that it's not really acting on anything. So that's the first thing, the blood flow. So we talked about stasis earlier. Blood flow will dilute out the thrombin. But really, whenever it acts really locally nearby, let's zoom in and see what happens. So when we get thrombin acting right here, let's make it purple again. We got our purple T. And it's going to act on the endothelial cell, so it'll bind to its receptor here, act on the endothelial cell, and that endothelial cell will release Tpa. So I think I said in a past presentation, mistakenly, that thrombin will activate Tpa. That's not the right wording. It doesn't activate Tpa. Tpa is active. It's just inside the cell, and it needs to be let out of the cell, and so that's what thrombin does. So Tpa, that's tissue plasminogen activator. So we got my plasminogen. I'm going to get it activated to plasmin. So then that plasmin will go back to the site of the clot. Well, it doesn't travel. It doesn't have a flagellum, but it will get back to that clot, and it will chew up the fibrin and the fibrin cross-linking, and you will have degradation of the clot. Now, this is an important point. Plasmin can do two things. So it can degrade fibrinogen. This is the inactive. There's been no strengthening. There's been no cross-linking. And it can also degrade fibrin with cross-linking. So this is important because when you're looking at different pathologies, you're wanting to know, well, do I have an increase in fibrin degradation products? So whenever you degrade this fibrin and this fibrinogen, you'll get similar products. However, what is the D-dimer? The D-dimer is whenever you have a fibrin product that is dimerized and connected with another fibrin product. And so the only time you can get a fibrin product that is cross-linked to another fibrin product is whenever there's been cross-linking. And so that means there had to be a clot in that situation. And that's what the D-dimer is measuring. It's measuring the degradation of a pre-existing or existing clot. However, you can get bleeding diatheses, which are basically genetic or acquired overactivations of plasmin or over-release of Tpa. And in that case, you'll get bleeding diatheses, but there never was any clotting, so you won't get a D-dimer, but you will still get fibrin, basically fibrin degradation products. So that's just a side note, a clinical side note on looking at different bleeding problems. But now back to clotting. So we got thrombin. The other thing that thrombin is going to do is going to bind with thrombomodulin. Thrombomodulin. And I'm going to draw thrombomodulin as like the empty shell of a T. This is still purple. So that's the empty shell of a T. And then when my thrombin goes and combines with it, it becomes the thrombin-thrombomodulin complex. What is thrombomodulin? Thrombin used to cause clotting, and so now it's modulated so that it will inhibit clotting. And what it does is it will activate protein C, and protein S. So these are two different proteins. Protein S is a cofactor for factor C. So typically we'll just talk about factor C, but know that protein S is its cofactor. And when the CS complex is activated by the thrombin-thrombomodulin complex, it will inactivate factor 5A, inactivates it, and it'll inactivate factor 8A. Now factor 5 Leiden is a point mutation in factor 5. So factor 5, a point mutation, and it's a substitution of basically glutamine, that's glutamine, to arginine. Just a single point mutation. And what this does is it prevents the inhibition of factor 5 by protein C. So factor 5 stays active. When factor 5 stays active, what you'll get is increased clotting because you can't turn off that clotting factor. But when you test the PT and the PTT, they'll both be normal. They're normal because the clotting pathway, there's nothing wrong with the active clotting pathway. What's wrong is turning off the clotting pathway. And PT and PTT don't test how well the clotting pathway turns off. It tests how well the clotting pathway actually runs. So they'll both be normal. Now there's one other thing I didn't put on here that's mentioned in the newest edition of Robbins, and that's the tissue factor pathway inhibitor. Tissue factor pathway inhibitor. This is basically something that sits on the surface of the endothelial cell. And since I'm running out of endothelial cell, I'm just going to make a little bit more. So I'm going to add some collagen here, and then add a little bit more endothelial cell. So now this tissue factor pathway inhibitor, it also requires protein S as a cofactor for its reaction. And you'll remember that tissue factor is the same thing as factor 3, and it complexes with factor 7 to become a factor 10 activator. So this will activate factor 10. But this tissue factor pathway inhibitor will block this complex. It doesn't block tissue factor itself. It blocks the tissue factor complex, the 7-3 complex. And this, as you can see, sits on the surface of endothelial cells. And I just took one more look at my notes because I felt like I was missing something, and voila, I was. There's one more thing that endothelial cells produce. It's called adenosine diphosphatase. So quickly, you'll remember that we have a von Willebrand Factor multimer right here, and we get GP1 binding to it from the platelet. When it binds, the platelet changes shape. It increases its surface area, and in doing so, it degranulates, releasing ADP and thromboxane A2. Just as a side note, you'll want to remember that the granules that they're stored in are called dense granules or delta granules. The platelets have two primary types of granules. They have the dense granules and they have the alpha granules. And the alpha granules contain P-selectin, so P-selectin, and they also contain some clotting factors. So dense granules, ADP and thromboxane A2, when they're released, they act as autocrine and paracrine. So they act to induce GP2B3A on themselves and on other platelets. And it's through this GP2B3A receptor that fibrin can allow the platelets to aggregate together. Now, if I have adenosine diphosphatase, I will stop the autocrine paracrine activity of ADP because I'll chew up the ADP as it comes out of the platelet. So I'll be able to get platelet adhesion, but it will prevent aggregation. And this is kind of an important exercise. It might be useful to go back, rewind this, and say, for each of the things that I've shown you for the endothelial cells, ask yourself, if I only had that one thing active, how far would I get in the clotting? Would I get to adhesion? Would I get to aggregation? Would I get to fibrin cross-linking? Would I get to, and where would you get with each one of those things? So now the whole point of this is clinically, what can cause endothelial damage and cause hypercoagulability? And so some things that can cause the endothelial damage would be hypoxia, acidosis, and shock. So basically, all of these things will just kill the endothelial cell, especially hypoxia and shock, acidosis to a lesser extent. Endotoxins in general from gram-negative bacteria, these do through a variety of mechanisms, including direct damage to the endothelial cells as well as activating TNF and the impact that TNF has on the endothelial cells as well. Atherosclerosis. This will both impair the endothelial cell and it will also cause turbulent flow and also cause stasis. Rickettsia and meningococcal bacteria. So Rickettsia is Rocky Mountain spotted fever. This bacteria is known to just infect the endothelial cells, and that infection induces a DIC. So if you have a patient from the mountains of South Carolina and they look like they're having DIC, you do their bleed time and everything, their PTT, and it's off, then you should suspect rickettsia. Now, just tissue injury, these are general concepts like getting burnt, having a surgery, a fracture, getting into a fight, getting punched too hard, anything that can actually just cause mechanical damage. Temperature extremes is another thing that can cause damage. And then homocysteine, I've got question marks here. Ask me why. The reason why is because there's a bunch of proposed mechanisms for hypercoagulability with increased levels of homocysteine. And hopefully I'll have time to talk about those. And then last of all, vasculitis. Vasculitis is going to include things like amyloid deposition into the vasculature. It's going to include things like autoimmune deposits of immune complexes. And so I've given you a mnemonic because this is a lot of stuff. It's not really like, you can kind of think through it, but a mnemonic just in case you want to memorize it quickly. A hearth is the floor of a fireplace, and so that's where your tissue gets damaged, on the floor of the fireplace. Hearth standing for hypoxia, endotoxin, atherosclerosis, rickettsia, tissue/temperature, homocysteine, and then you just got to remember hearth and vasculitis. Okay, so here's my vessel, and here's my blood flowing through the vessel in this direction, and you'll notice because there's so much shear stress up here, the movement is faster towards the center, and there's a higher stress towards the outside. So what this actually does is it pushes all of the cellular and large products toward the center of the vessel when the flow is good. Whenever the flow slows down or becomes turbulent, in either of those cases, these things can be marginated toward the side, just like leukocyte margination. And so whenever the flow of blood slows down, you get margination of also the platelets, and that gives them an increased opportunity to clot. Secondly, when there's reduced flow, you have something called reduced washout. So those procoagulants, if they can be pushed down into the stream of blood and become diluted, they'll have less impact. And so if you don't get that, you don't get the washout, then you have increased clotting because those procoagulants are highly active in one area. And lastly, Robbins mentions activation of the endothelial cells. It doesn't really give a mechanism on how reduced flow causes activation of endothelial cells or even exactly what that means. We know what activation of platelets means. But nevertheless, it says that this can increase leukocyte adhesion. So we're probably talking about expressing the selectins and the integrins and the cell adhesion molecules, the CAMs. And so my thought is, and I think I've read this somewhere, that the endothelial or that the leukocyte migration onto the endothelial cell can cause either exposure of collagen or it can cause damage to the endothelial cell itself. Now, how do you get stasis in your blood flow? Well, you can have heart wall stasis, which is from an MI where you have reduced movement in one wall of the heart, or you can have AFib where the entire top of the heart is not moving. You can have prolonged immobilization, that's bed rest, that's also sitting on a plane for 14 hours and not getting up to go pee, and then aneurysm. So what I have for you right here is a vessel that has a big aneurysm in it. And so you can see we have a very narrow area, and then we have a very wide area, and then it goes back narrow again. Now, what we're looking at with stasis is how much blood is moving through. So what is the volume? So I want to know what the volume is. And let me change that back to black. So what is the volume? The volume is going to be equal to this cross-sectional area, the cross-sectional area multiplied by the length of the column of liquid. So if we look at flow rate is going to be volume per unit of time. So I just need to figure out what the volume is. We know through conservation of mass that what goes in has to equal what goes out. And so the volume is going to be a constant thing. And that's kind of confusing wording, but you'll see what I mean. Let's assume that this entire area is 1 milliliter. And let's say that this entire area right here is also 1 milliliter. When we have 1 milliliter going this length, let's call this length 1 centimeter. It will also cause in that same amount of time the 1 milliliter to move this distance within the aneurysm, and let's call that 0.1 centimeters. So if in that unit of time, let's say it's 1 second. Up here we have 1 centimeter of flow per second. And down here we have 0.1 centimeters of flow per second. So it's moving much slower. Same volume, but moving much slower in this dilated area. And so those are your main things with stasis. You're going to have heart wall stasis, which is MI or AFib, prolonged immobilization, so you can do prophylaxis for that, and you can have aneurysm. Okay, so now I'm going to talk about hypercoagulable states, and specifically I'm going to talk about acquired hypercoagulable states, not genetic. But according to Robbins' pathologic basis of disease, a thrombosis should be worked up as possibly being genetic, even if there are predisposing factors if the patient is under 50 years old. So in essence, under 50 years old, we're saying there's not enough endothelial damage, there's not enough reduced flow. So even in the event that there is a good chance of having a hypercoagulable state, it should have less impact on someone under 50 than someone over 50. And since it has less impact, if we have thrombolic events, we should also consider genetics in our differential. Okay, first of all, we're going to talk about a hyperestrogen state. What is that? You have a hyperestrogen state during pregnancy and postpartum. You also can have that with when you're taking certain oral contraceptives. And obesity, we know, causes hypercoagulable state, or it causes increased risk of thrombosis, but the mechanism is stated to be unknown. However, we all know from biochemistry that adipocytes can convert androgens into estrogens. And so I just put that on here with question marks. And so what does estrogen do? Primarily, it's going to act on the liver. And in the liver, it's going to increase the production of clotting factors and decrease the production of anticoagulants. Okay, now cancer. We have bronchogenic and pancreatic cancer, which we are all familiar with, cause Trousseau's sign of malignancy, also called thrombophlebitis migrans. If I'm saying or spelling it right, I don't know. I personally prefer Trousseau. And then also you can have hypercoagulation with several different adenocarcinomas. These will typically lead to DIC. And then also with acute promyelocytic leukemia. Now let me explain. The mechanism on all these is pretty much the same. First, necrotic tissue will get into the bloodstream. And second, I don't know if this is talking about the same thing or two different things, but I've seen both of these stated in different sources. Mucin production and mucus production. I think it's talking about the same thing. This occurs with both the bronchogenic and pancreatic as well as the adenocarcinoma, because you get mucin production. And what this does is it will directly activate factor 10 without the factor 7-3 complex. So we no longer need this. We get rid of it. Mucin's doing the job to activate factor 10. And then we also know that in cancers, we get increased production of TNF, as well as IL-1 and IL-6. And so all of these can have an increase because they are going to impact the endothelial cells, impact the liver. All of these things are going to increase coagulation. Now with acute promyelocytic leukemia, you have one other thing, and that is they release granules. And you'll remember that the granules in these contain hour rods. Now I couldn't find if the hour rods were directly responsible for this, but it's the components in the granules that are considered prothrombotic. So old age is a risk factor. We said anything under 50, we looked for genetics. Over 50, we're not so concerned. The biggest thing with old age, and I didn't even mention it a second ago, is that you have reduced production of PGI2. PGI2, remember, is going to decrease ADP by producing cyclic AMP, and it's going to reduce the cyclooxygenase pathway, which is going to end up reducing thromboxane A2. And also PGI2 is a vasodilator, so we get vasoconstriction. Or so we would get vasodilation with it. And just endothelial cells in general will probably reduce, besides this PGI2 and all of the things that it does, it will probably also reduce nitric oxide, and it will probably also reduce adenosine diphosphatase. Now, renal failure. This one's tricky because the literature will report that renal failure increases coagulation, and it will also report that it increases bleeding. So you get bleeding diathesis, or decreased coagulation, you could say. So it goes both ways with renal failure. And I have a really good workup on this in the study guide. Go ahead and look at it if you're curious, but I do not think it's high yield because most of it's speculation. So what you'll also get is what you get with this is a decreased clearance of homocysteine, which may cause endothelial damage and a few other things. You have increased oxidative stress, so all of this looking at endothelial damage possibly. And it's important to know that it's different mechanism than the nephrotic syndrome, where you can get hypercoagulation with that. So because there's a really interesting thing about this, and because it's all talking about renal failure or uremia, I think it's also important to mention the mechanism of increased bleeding that's proposed in the literature. So we normally think of von Willebrand factor as binding to GP1B, but in high shear stress areas, high shear stress, that would be in the microvasculature. In high shear stress areas, it's thought that von Willebrand factor probably binds to GP2B3A. So in those situations, there is in uremia, there's a conformational change in the GP2B3A receptor. It's not so big that it would stop GP2B3A from binding to fibrin and cross-linking to other platelets, but it's enough that it would stop the von Willebrand factor from binding to it. Also, there are proposed substrate competitions. So, for example, urea, guanidine succinate, parathyroid hormone, phenol, and tryptophan products are all proposed substrates that are competing for the GP2B3A receptor. However, the most recent evidence shows this RGD substrate. RGD stands for arginine glycine aspartate. These short sequences accumulate in uremia due to decreased clearance, and they have been shown to both reduce von Willebrand factor and reduce fibrinogen binding to GP2B3A. Then last, with uremia, the last theory, I guess, is that there's increased production of PGI2, also known as prostacyclin, and increased production of NO, or at least there's increased serum NO. There's a decreased total body NO, so figure that out. And we've already talked about the mechanisms of how these would interact with the clotting pathways with platelet plug formation. Now you have your platelets, so let's talk about heparin-induced thrombocytopenia. So you have your platelet, and sitting on that platelet, we have something called platelet factor 4. I decided that PF4 should be blue. Heparin will bind to platelet factor 4, and then sometimes antibodies will form against this complex. When this happens, it causes activation of the platelet. It doesn't inhibit the platelet, it causes activation. You remember what activation does. You get your ADP, you get your TXA2, you get your increased GP2B3A, and then you get clotting. So this leads to tons of clotting. Clotting will use up all the factors, clotting factors, and it will use up all the platelets, so you get thrombocytopenia from low platelets. They're all used up, and you get low factors, so you have increased PT, PTT, and INR. And that's really all I have to say about that. Well, actually, I do have one more thing to say about that, and that's this, that when you have unfractionated heparin increases your risk of HIT. So whenever you get HIT from unfractionated heparin, at that point, low molecular weight heparin does not help. So I'll write help and I'll cross it out. It does not help at that point. But if you start with low molecular weight heparin, you have a reduced risk of HIT. And Satar points out that when you have heparin-induced thrombocytopenia, you do not want to switch the person to Coumadin, because then they're at increased risk of skin necrosis. And that all has to do with how fast factor C has a half-life. Protein C has a half-life that's much shorter than the rest of the clotting factors. So if you switch straight to Coumadin without heparin, then you're going to deplete your anticoagulation factor first, and you'll get coagulation until the rest of the factors are gone. So what I'm saying is this. You have factors 10, 9, 7, and 2, and CNS that are vitamin K dependent. And what vitamin K does, active vitamin K, as soon as this factor is made, it will come down and carboxylate these factors. So once it carboxylates it, it becomes vitamin K inactive. And that vitamin K inactive has to become reactivated by vitamin K reductase. It's vitamin K epoxide reductase. So I'll put vitamin K epoxide reductase. Scratch that out. We'll form it back into active vitamin K. And then whenever a new factor 10 is made, it can come over here and it can carboxylate that new factor 10. And that old factor 10 can go and get broken down and eaten up and used in some other biochemistry for its amino acids. But what happens if we can kill off all the vitamin K and all of the new factors that are produced won't be carboxylated? So first, all of the CNS gets eaten up first and we start producing new C and new S, but it's inactive. It can't do its anticoagulation pathway because it's inactive. It has to be carboxylated. So we have to wait until all of these other factors are depleted and get replaced with non-carboxylated factors before we can mitigate the risk from protein C and protein S not being carboxylated. If you don't do that, you can get Coumadin skin necrosis. So let's talk about Antiphospholipid Syndrome. This is another autoimmune. Okay, Antiphospholipid Syndrome. This is our next one. Let's suppose, let me get some yellow out here. Yellow is my phospholipid surface. Let's suppose I have a phospholipid surface and then I get a protein. I'm going to make my protein brown. So I get a protein that goes onto that surface. Whenever it gets on, so it's not on the surface yet, it's floating above it. Whenever it gets on that surface, it has a change in shape, or it changes something about it, and it exposes this brand new area that was never exposed before. This new area becomes antigenic, and I get antibodies that bind to it. So while we call it antiphospholipid, it's not really, it's antiproteins that are bound to or interacting with phospholipids. Now, this used to be called lupus anticoagulant because whenever you took the person's blood, if it had these antibodies in it and you tested it to see how it would do on a protime or a prothrombin time, PT, PTT, it would increase the protime and prothrombin time. And that's because the phospholipid surface, the phospholipid that we're using in this pathway would interact with the clotting factors in such a way that it would reduce their activation. But in vivo, with our body's own special phospholipids, the interaction of these clotting factors, you'll remember that several of the steps in the clotting cascade have to take place on a phospholipid surface, specifically on the phospholipid surface of the platelet. You'll remember 3 things are required for clotting. You have to have a phospholipid surface. That's from the platelet. You have to have calcium. And you have to have an activating substance. Now, people that have this antibody that they're making will also typically bind to the cardiolipin antibody. So let me change this color to green so I can circle it better. So this antibody right here will also bind to the cardiolipin, and so that's the syphilis antigen. So people that have syphilis, I think I misspelled that, but people that have syphilis will also make an antibody that binds to cardiolipin. And so that's the test. We say, do you have the antibody that binds to cardiolipin? If yes, you have syphilis. But people that have antiphospholipid syndrome also make an antibody that binds to cardiolipin. And because of that, it will give a false positive on the VDRL. Okay, another DIC. DIC is always acquired. It's never a disease state in and of itself. It's always an acquired thing. So let me eat my words just for a second. DIC is never its own thing. It's always caused by something else. So typically, that something else is an acquired hypercoagulation. So you can get thromboplastic substances or you can get endothelial damage. That's the two things that cause DIC. You'll remember endothelial damage is the HERTH plus vasculitis. Now, gram-negative endotoxin is sort of a mix between both of these, but you can just think of thromboplastic substance, endothelial damage, and gram-negative endotoxin. Now, what are thromboplastic substances? Well, you can have necrotic tissue from a fetus. This will cause embolus. You can also have amniotic fluid. And this is important because amniotic fluid contains tissue factor, remember also called tissue thromboplastin, also called factor 3. You'll remember from our talk on acute promyelocytic leukemia that the granules are thromboplastic substances. You'll remember from the adenocarcinoma that the mucus or mucin is a thromboplastic substance, directly activating factor 10. And one that is tested, so says Satar, rattlesnake venom. Rattlesnake venom is a thromboplastic substance. So the diseases that DIC is commonly seen in, major trauma, obstetric complications, malignant neoplasms, and sepsis. So you can remember your moms. Oh, and I guess I had all this stuff on my slide and I had forgotten. But there you go. Those are thromboplastic substances. And that's all I got for you.